So SARI-PREP is a multi-center consortium. It's a study of academic medical centers and a national critical care research network. SCCM's Discovery Critical Care Research Network serves as a data and clinical coordinating center for the study. This consortium came together with the goal of providing the infrastructure to rapidly collect prospective data on clinical risk, outcomes, hospital-level stress, and biological specimens to aid in the development of diagnostics and therapeutics. And so we're going to have 4 different speakers. We'll have some time at the end for questions. And so our first speaker is John Sevransky. He's going to be talking about the impact of SARI-PREP and beyond. He's a professor and interim division chief at the division director for pulmonary, allergy, critical care, and sleep medicine at Emory University.
Thanks, Pavan. I very much appreciate the chance to talk a little bit about the rationale for why SARI-PREP was developed. And then after I finish, my younger and smarter colleagues will talk a little bit more about some of the data and some of the implications. So briefly, my disclosures, both the intellectual and financial ones. And really, what I want to do is talk about something that we've all lived. We had to learn on the fly to treat patients during a pandemic. And to learn how to treat patients better, generally you need to do some form of research. And that will lead into an overview of what we did with SARI-PREP. So when you're suddenly faced with overflowing emergency rooms, with staff who are out sick because they're ill, busy ICUs, it's really tough to figure out how to treat a disease that you haven't seen before. And this is especially true because it's sort of the worst of all possible situations. You've got a disease or a syndrome that you don't know what's effective. There's a lot of noise in the media and from your colleagues about what might work in this novel situation. You're all working harder, and it's unclear as to whether or not the stuff that has worked in the past for other diseases works for this new disease. So oftentimes, you're stuck talking to colleagues, saying, have you seen this before? What do you do, and how do you do this? And this leads to some rapid research and rapid publication of stuff that sometimes isn't quite up to par. Thank you so much. And there were a number of publications in high-impact journals that got rapidly retracted. And some of them in our journals, including some prominent people who are advocating for methylprednisolone, ascorbic acid, thiamine, and heparin, or the MATH Plus protocol that also was rapidly retracted. And there were a fair number, there was actually a systematic review of retractions showing how many and how well or poorly manuscripts that were turned out to be based on incorrect science or incorrect data got pulled out of the literature. And one might think that, yes, this is only something that will happen once in a lifetime, but from this review by Bram Rochberg and colleagues in Critical Care Explorations, you can just see the number of viral pandemics over the last few hundred years. And you'll notice that for current lifespans, it's likely that this will not be the last one that we see. So how do you make decisions in a pandemic? Again, we've all done this. And usually we change our practice based on high-quality studies in high-impact journals, systematic reviews, meta-analyses, taking a look at whether or not these high-quality studies will translate into your population. That's how we usually do things. In the middle of a pandemic, we're stuck with using indirect data from different patients. There's a lot of expert-driven care, figuring what might work in other hospitals or jurisdictions. And sometimes you have to make decisions that are both high impact, but also perhaps not based on the best science. And that's one of the reasons why having consortiums such as SARI-PREP help. So this is a collaboration, and you can see the institutions up over here, between the Discovery Research, Critical Care Research Network, funded by the CDC Foundation, the Society of Critical Care Medicine, NETEC, the Resilience Intelligence Network, and a number of academic institutions. And from the protocol paper, which is listed here, and the clinical trials, this is basically the plan, is that you find patients with an upper respiratory infection. During COVID, it was primarily COVID, but now we're enrolling more patients with other diseases. The administrative core is at the University of Washington, led by Laura Evans. There was a single IRB, a Clinical and Data Coordinating Center. Should note that the chair of the Data Coordinating Center is now at Indiana, and a central lab at the University of Washington. And there was lots of data and blood samples that were collected. And with that, that's the introduction, and again, you're going to hear some of the science that's come out of this from my distinguished colleagues. And I think we're going to save time for questions at the end, so I'm going to just have Pavan come up.
If I could get my slides, do I? Thanks, John. So again, my name is Pavan Bhatraju. I'm an assistant professor in the Division of Pulmonary and Critical Care at the University of Washington and director of our Sepsis Center for Research Excellence. So the title of my talk is Molecular Measurements in our cohort here is SARI-PREP, a multi-center prospective study. These are my funding disclosures. So the learning objectives are to describe the first 800 patients enrolled in SARI-PREP, and these were patients with severe acute respiratory infection, including COVID-19, as well as other viral infections. And then to briefly highlight some of the analyses that we can do with this type of cohort, and what are some of the scientific discoveries we can find. So John talked a little bit about this, but SARI-PREP was really a collection of different regional as well as national collaborations and bringing them all together, including NETEC, the Society of Critical Care Medicine, and then the CDC Foundation was a primary funding entity. And the protocol paper was published in the Critical Care Explorations in the Radu Polstenico, as well as other authors. So some of the goals of SARI-PREP are to advance our understanding of SARI and potentially do a deep dive into the epidemiology, the pathophysiology, and the molecular phenotyping. And then the overall planned enrollment includes 1,200 patients in a 3-year prospective observational cohort study. We talked a little bit about the different sites, but I think one thing we wanted to highlight was when we're including sites to enroll patients, we're really trying to have some geographic diversity. As was seen early in the pandemic and even still in the pandemic, there's different places of the US that are affected by the pandemic and affected by a number of cases of different viral respiratory infections. So this slide is a little outdated, but this was enrollment to date up to December 2022. So enrollment started early in the pandemic in April of 2020. And then currently we've enrolled approximately 820 patients. There's been 2,600 individual plasma aliquots, 800 different nasopharyngeal swabs, urine specimens, and peripheral blood mononuclear cells. And we're really taking a holistic approach to looking at these different biospecimens and leveraging the expertise within the consortium. So plasma and urine proteomics was done at the University of Washington, and I'll talk a little bit more about our initial findings with that. Humoral profiling is done at Nebraska with David Brett Major, as well as Jana Broadhurst. Peripheral blood transcriptomics is done by Leo Siegel at NYU. Viral sequencing for all the swabs, all the patients that were enrolled had viral sequencing completed. And then we did human genotyping also at University of Washington. And then George Anesi later is going to be talking about the hospital stress and strain surveys that were completed by all the sites. So then briefly, I wanted to talk a little bit about the proteomics analysis. And so what we did with the proteomics analysis was that we wanted to do a discovery proteomics approach to understand what potential pathways are dysregulated in COVID-19, what pathways are upregulated that explain the poor outcomes that we're seeing. And so we started with 101 COVID-19 patients. We did a proteomics screen using a platform called SomaScan, which is a somologic platform. It uses short oligonucleotides that bind to different proteins. And the value of SomaScan is we were able to measure 5,000 proteins at once in one single blood specimen. The other benefit is the coefficient of variation is quite low on these measurements. And so you can have good generalizability and reproducibility of what you're finding. And then the final thing is we can potentially see what we're seeing in our cohort and apply it to other studies that use a similar platform. So the primary outcome we looked at in these analyses was 28-day ventilator-free days, as well as hospital mortality. And this is a volcano plot of our primary results. On the figure on the left, so on the x-axis are risk of ventilator-free days. So numbers right of 0, or each dot is a protein. And then so proteins right of 0 are associated with higher or better outcomes, more ventilator-free days. Proteins left of 0 are associated with fewer ventilator-free days. And so this is out of 101 patients. You see that one of the top proteins was angiopoietin-like 4. That's a protein that's highlighted in red there. I think the other thing to really highlight here is there are a number of proteins that are differentially regulated between the outcome of ventilator-free days. Many that were associated with improved ventilator-free days and others associated with worse. Next, what we did was, while we did this proteomic screen, we found that ANGPTL4 may be one of these top proteins. We wanted to see, can we measure this using an ELISA, and can we do it in a multi-center cohort? And so using patients that were enrolled early in the pandemic in SARI-PREP, 225 patients, we found that higher ANGPTL4 concentrations were associated with hospital mortality. The next thing we looked at is we had serial blood specimens collected during hospitalization. And so what happens over time? On hospital admission, we found that the concentrations of this protein differentiate who's at development of poor outcomes, but what happens during the first 2 weeks of hospitalization. And we find that patients that ultimately go on to dying in the hospital have higher concentrations, and those rise over the first 2 weeks. And then finally, we looked in vitro in cell culture in distal airway epithelial cells and saw if we expose these epithelial cells to SARS-CoV-2, do we find upregulation of ANGPTL4? And we found here on the figure on the left, you see that at 24 and 48 hours, there's increased ANGPTL4 expression. And what's particularly exciting about this pathway is that this protein has been implicated in other viral infections, and I'll talk a little bit about that. But there's two domains, and the C-terminal domain is the one that's associated with endothelial leak, capillary permeability. And then here, early in the pandemic, there were 2 papers that suggested that the receptor for ANGPTL4, this is a receptor called neuropilin, is upregulated in COVID-19 and a co-receptor for SARS-CoV-2 entry into different epithelial cells. So potentially arguing that if a patient has SARS-CoV-2, maybe they have upregulation of the receptor where ANGPTL4 binds, and then ANGPTL4 is more biologically active. And then finally, there's been 2 preclinical studies that have shown that you can potentially modulate this pathway. So an inhibitor to ANGPTL4 in mice models improved outcomes in influenza as well as streptococcal pneumonia. So again, highlighting that potentially what we're finding in SARS-CoV-2 is maybe a druggable target. And then here's just a list of some of the other work that's come out of the consortium. So looking at how do kidney epithelial cells, do they get infected with SARS-CoV-2 and what happens with kidney outcomes in the ICU. Another one looking at the endothelial pathways in COVID-19. And then finally looking at the microbiome and secondary respiratory infections and COVID. And so in conclusion, SARI-PREP is an ongoing observational cohort study. We're going to be enrolling till the end of this year. And then current enrollment includes different respiratory viruses, SARS-CoV-2, influenza, as well as RSV and others. And the early molecular features of COVID-19 illness in the ICU, we're able to compare this with other viral infections. And then I'm going to hand it over to George Anesi, who's going to be the next talk. George, let me. So just to give a brief introduction for George is an assistant professor of medicine at the University of Pennsylvania Perelman School of Medicine and an attending physician in pulmonary and critical care medicine at the hospital of the University of Pennsylvania. He has a clinical epidemiology and health service research program focused on capacity, strain, and preparedness. And he directs the PENS Bioresponse Program and Special Pathogens Treatment Unit.
Thank you so much, Pavan and John, so far. Thank you very much for the opportunity to speak today. I am a medical intensivist and a clinical epidemiology researcher, and I study this phenomenon of healthcare capacity strain. And so I was brought into the SARI-PREP group to look at the simultaneous measurements of hospital stress and strain that were going on during the pandemic alongside the rest of the SARI-PREP study goals. So I'll be talking today about severe acute respiratory infection and hospital stress patterns and impact, and this is the results of that work. Here are my financial disclosures. I'm funded by federal and foundation sources, and I have a few financial relationships, none of which I think pose a conflict for today's talk. So as was mentioned, SARI-PREP is a CDC Foundation funded and SCCM discovery housed multicenter prospective cohort study, and the primary goals as were outlined are looking at SARI patient care and clinical biologic characteristics and outcomes. But we were separately motivated by the idea that hospitals experience substantial stress during the COVID-19 pandemic. We define that as threats to standard operations, and it's not well known how this stress manifested at individual hospitals aside what each hospital knows about their own experience, but not as kind of a collective population of hospitals measure, which would be very important for preparedness efforts and kind of future-looking preparedness. So we aim to understand four things with this study: patterns of hospital stress over time, where stress was located within individual hospitals, within hospital correlations between individual stress measures, and then temporal relationships between stress measures and local SARS-CoV-2 case activity. So these data were collected with a weekly hospital stress survey that was part of the SARI-PREP study. This was deployed from November 2020 through June 2022. It's been since modified, but the data that we'll present today is through June 2022. And it had rolling cohort entry, so SARI-PREP study sites, as they came online in the study, could also enter the stress survey data collection. And the respondents were SARI-PREP site leaders or their designees at each individual site. And the survey assessed a number of things. It assessed perceived stress, that is to say, reported and perceived by the respondents at different levels, at the hospital level overall, in the emergency department, and in the ICU. It measured a host of deviations or potential deviations from standard operating procedures that we'll go through, and then staffing and equipment availability. This is a map of the SARI-PREP study sites on the left, almost all of which, but not 100%, were involved with responding to the stress survey. And here's a list of the sites, both the health systems and individual hospitals, and their kind of rolling cohort entries. You can see how different sites ended up entering the study over the course of the last 3 years. In addition to the data collected in the survey itself, we also extracted state and county SARS-CoV-2 case counts from public health departments and standardized those per capita as an additional a data point to link with the stress survey data. We categorized those SARS-CoV-2 case counts as periods of surges or between surge periods, and the surges were defined by weeks that included a day with a 60,000 or greater incident SARS-CoV-2 cases nationally. And our study period covered essentially 5 waves, the third of 3 ancestral waves, and then Alpha, Delta, Omicron BA1, and Omicron BA2.12.1 in the early parts of BA4 and 5. And then between surge periods, which were weeks that did not include any days with that greater than 60,000 incident cases, made up about 26% of study weeks, those between surge periods. We had 2 units of analysis. The first was hospital week. So this reflects the experiences of individual study hospitals and was used for within and among hospital analyses. And the second is pandemic or study week or calendar week, and that was useful for across pandemic analyses, including among variant analyses. And we did 4 modeling approaches to answer those 4 priority questions I put forward earlier. So the first is to look at the correlation between individual stress measures, and for that we used a Spearman's correlation coefficient analysis. The second was to look at the association between SARS-CoV-2 county cases and hospital stress. For that we used multivariable logistic regression adjusted for the variant surge period and the hospital on the level of the hospital week. And then for among hospital variation in stress, we looked at, again, a multivariable logistic regression models, this time stratified by hospital and adjusted for SARS-CoV-2 case counts. And then finally, to look at the temporal relationship between SARS-CoV-2 cases and hospital stress, we measured different time intervals, the first from the start of stress measures to the peak of local cases, then from the peak of local cases to the end of stress, the total duration of stress, and then the level of case counts, of SARS-CoV-2 case counts locally at the start and end of stress for each of those metrics. And then for each surge period and for each stress measure, we compared them using 2-sample Wilcoxon rank sum testing. So here are the results. The data I'll present today is from 13 hospitals across 7 health systems and 6 US states that span 85 pandemic weeks, so 85 calendar weeks, and then 839 total hospital weeks of data, and 5 variant surges. This is kind of an overview of how these data came together. So the x-axis is time, and the black line indicates the SARS-CoV-2 cases for all the contributing counties during that time period. The red, green, and blue lines represent hospital, ICU, and emergency department stress, perceived stress by week, cumulatively over all of the study hospitals, a percentage of hospitals reporting for each of those. And then the shaded periods represent the 5 different surge periods, different variants, with the white being between surge periods. And you can certainly see correlations. I'll show you the specific analyses in a moment, but correlations between case counts and stress, and potentially different patterns of stress between different stress measures. We collected a huge amount of data with this. I'll just highlight a few things. The first is that over the full study period, hospitals reported stress on the whole hospital level, around 43% of hospital weeks, in the intensive care unit around 32% of hospital weeks, in the emergency department around 14% of hospital weeks. And the most common deviations from standard operating procedures were increasing hospital staffing, denying inter-hospital transfers, and canceling elective surgeries. Those occurred in 19, 15, and 14% a week. So a substantial disruption for normal operating procedures. The Omicron BA.1 subvariant surge in particular was very disruptive across reported stress and across reported care deviations. But even during between surge periods, things did not return to normal. So 14% of hospitals were still reporting hospital stress on any given week. When we looked at correlation between different stress measures, ICU stress was highly correlated with overall hospital stress with a rho value of 0.82. But emergency department stress was much more moderately correlated with both overall hospital stress and ICU stress, and we can take a look at that in a moment. And then from a standpoint of association between local SARS-CoV-2 case activity and hospital stress, we found there was indeed an association. And so for every 10 new SARS-CoV-2 cases, or 10 additional SARS-CoV-2 cases per 100,000 residents, we would expect by this analysis to see an 8.7% increase odds of hospital reporting stress that week, a 6.5% increase odds of the ICU reporting stress, and a 3.8% odds of stress in the emergency department. And then when we looked at between or among hospital variation, this is data from the Omicron BA.1 subvariant surge. We have our 12 study hospitals at this point displayed on the x-axis. And then on the y-axis is the percent of weeks during this period that they reported stress with the 3 different primary measures: hospital stress in red, ICU stress in green, and ED stress in blue. And then you can see, going from hospital 1 all the way up to hospital 12, there was significant variation, even within the same surge period, with how often these hospitals were reporting stress. So different hospitals are certainly experiencing these acute surge periods differently. And then finally, the results of our analysis looking at the temporal relationship between SARS-CoV-2 cases and hospital stress. To orient you, the left figure is the Delta variant surge, the right is the Omicron BA.1 subvariant surge. The y-axis is county SARS-CoV-2 cases per 100,000 population on a county level. The x-axis is weeks, with the zero line aligning with the peak of SARS-CoV-2 cases. And so you can see the black curve is SARS-CoV-2 cases that come up, peak, and then descend. And the indicators are for, again, red, green, and blue, overall hospital, ICU, and ED stress. And the first three are the start of stress, and the next three squares are the end of stress. And so I'll point out a couple things. One is that all the measures of stress seem to start around the same time, and they do so either at the peak or in the run-up to the peak. But on the contrary, or in contrast, the end of stress is much later. So in the Delta variant surge, it took 6 weeks for ED stress to abate, and it took 10, 11, 12 weeks for ICU and overall hospital stress to abate. And in the Omicron BA.1 subvariant surge, it took, again, 5 weeks for ED stress and kind of 5.5 to 6 weeks for overall hospital and ICU stress. So in certain scenarios, ED stress may abate a bit earlier, but probably the most predominant finding here is that perceived stress, at least, persists well after SARS-CoV-2 cases peak and decline in a given area. And that has potential implications for hospital preparedness, for staffing, resiliency, and so forth. So I'll conclude by saying that hospital stress and care deviations during the COVID-19 pandemic were common. They varied by surge period and by hospital, and perceived potentially avoidable patient harm was present but rare, perceived. SARS-CoV-2 county cases was associated with overall hospital, ICU, and ED stress. And then overall stress during the pandemic for SARI patients was highly correlated with ICU stress, but only moderately correlated with ED stress. And then finally, hospital stress measures persisted for weeks after surge's peak, potentially with emergency department stress resolving the earliest. We have a lot of future work that's ongoing or planned. I'll mention a few of these. One is to look at, we'll be linking this data set with the primary SARI-PREP patient-level data set to link hospital stress with patient-level processes of care and outcomes. We'd like to link perceived stress, this is stress sensed by and reported by clinicians and leaders, with quantitative measures of hospital stress, things like occupancy and acuity of patients within a hospital. There's other nuances that we'd like to look at between individual strain metrics and individual strain metrics and their relationship to local cases. And with the overarching goal here, looking at developing a more sustainable longitudinal surveillance program that can pick up early changes for future threats. So I'll stop there. I just want to thank the many, many collaborators that contribute to this study, all the different study sites, the funder, the CDC Foundation, our home, and SCCM Discovery. And then this is just a partial list of all the collaborators that worked on this particular part of the project. So thank you so much for the opportunity.
Thanks, George. I want to introduce the next speaker. It's Karen Luttrick. She's an assistant professor in the Department of Family and Community Medicine at the University of Arizona. Her research focuses on health disparities and equity in the Latinx and Hispanic community.
Hello, everyone. Very appreciative to be here with my brilliant critical care colleagues. I am in the Department of Family and Community Medicine. I do a lot of community and then also clinical research kind of across the severity spectrum for COVID. And so these are my disclosures. I have a lot of different COVID-related funding, again, from community surveillance, household transmission, the SARI-PREP, and then also some long COVID funding. So I'm really kind of talking about the impact and then also the beyond, kind of how we can take some of these lessons that we've learned in other aspects of understanding COVID in the pandemic and apply it to SARI-PREP. Big picture, right, when we think about using real-world data, when we think about trying to understand emerging threats or even existing threats, we really think about these gaps and limitations with collecting and using data. So these are kind of some constant issues that we continually run into when we think about clinical data. Timeliness, we can collect it quickly, but can we use it quickly? Data interoperability, so we have multi-sites, we have different data collection, we have different data capture forms, we also have different sort of terminology and understandings in our own institutions of the way things are kind of working and how we're reporting. Relevance, I think we learned this this hard lesson during COVID, things that were really relevant. If we weren't sort of agile and able to really adapt, we were out of sync with the pandemic in our research. And then continuity of care, which being in family medicine is something that I think about a lot, right? So folks come into our hospitals, they come into our ICUs, but do they get their follow-up care or their pre-care somewhere else? And so really kind of thinking about trying to link some of these data sets. And really trying to learn from what we were able to do with community surveillance. So I'm working on some large community surveillance cohorts with essential workers and kids. We've learned very quickly to do kind of constant QC, QA, merge data from multiple sites, very large data sets, to do weekly analysis. That has allowed us to, for example, we were able to do real-world vaccine effectiveness on COVID vaccines within 4 months of the vaccines being available. So we had a system we were constantly monitoring, and we can actually do power analyses every single week and decide when we have enough to sort of go forward with an analysis that we're confident in and that we can trust. And I have a couple of citations here just to kind of demonstrate. We were able to publish adult VE in March of 2021 when the vaccine came out in December, and kids VE in December of time doesn't work in my brain anymore. December 2021. Wow, that feels like much longer ago. When the vaccines for kids came out in over the summer. So again, trying to take these lessons and these tool sets and kind of this approach and apply it to clinical data. It seems kind of simple, but it's incredibly complicated, right? It's simple on the surface, but when you start to go deeper, it can kind of unravel a little bit. And so what we've done is we've leveraged the data infrastructure that we created for this community data to create some flexible and standardized systems to manage the sort of the multiple streams of clinical data that's coming into SARI-PREP. We have some very, again, on the surface, maybe simple goals, but in practicality, some complex goals. We do, our goal is to do weekly QA and QC to identify missing data, but also data that just doesn't make sense. So we're always testing for missing. Is it really missing? Should it be missing? But also sort of internal and external validity, kind of thinking about it the way we would validate maybe a survey. This makes sense in the context of this REDCap form, but does it make sense in the context of clinical care? Because if anybody that's dealt with EMR data knows, sometimes it just doesn't quite make sense. We are working on merging data that's being collected outside of the study EDC. It's a multi-site study. We have a standard electronic data capture system, but institutions use them differently, which means there's always a level of merging discordant data. There's always a level of merging old CRFs and new CRFs and slightly different sort of homegrown CRFs. Being able to generate descriptive tables regularly to understand patient characteristics. This is something that a lot of the community studies are able to. It's difficult to do in an EHR, like a clinical cohort that isn't an EHR-only cohort. So our EHR cohorts that are funded by CDC and such, they're able to do this, but they sometimes lack the context and the depth and sophistication that studies like SARI-PREP have. We have the biologics. We also have a human sort of going through and doing some interpretation of what's really happening and entering that data. And then to create merged analysis-ready data sets monthly that can be used to answer sort of existing questions, right? We have questions in the protocol, we have questions in the protocol paper, but there will be emerging questions, right? There are going to be new treatments, there are going to be new symptoms, there are going to be new variants. And so to be able to work towards being able to respond and really quickly using clinical data to analyze those. So just some kind of nuts and bolts stuff. Not everybody cares about this, so I apologize if you really don't think about data or enjoy data. But for the few of you that do, we've got code that was developed and we spent a lot of time kind of developing that code to be able to standardize and clean variables so they load properly into all statistical analyses programs. That seems so small, but it just is so important. It allows for really easy, kind of frictionless, kind of plug and go data analysis from a variety of folks. We check variables again to ensure they make sense. So yes, REDCap didn't flag it as out of range, but like, does it actually make sense for something that we should be seeing? And then we build missing data reports so that we can examine missingness across and within sites, but really quickly. So the idea is, while that patient is still in the hospital, if something's missing because it's not on the EMR, we can still go get it. We can also get it quickly, again, while we're still in that context. We also merge data. So again, we've merging this data across multiple systems. We've talked a little bit about that. Dr. Sevransky talked a little bit about the individual patients, but really we're thinking about the higher level, kind of more urgent data, the data that will allow us to answer really quick questions if there are new variants or we're seeing a new spike or a new peak. So the core data, the administrative, the demographic and sort of characterization of the illness, and then the outcomes is really what we prioritize to make sure that we're ready to be able to merge and analyze data really quickly. It allows us to do things like create a descriptive table. This is just a snapshot of a descriptive table that includes data from last week. So we were able to get the data from all the sites, merge it, and put out kind of a descriptive table. And so this doesn't include all of the participants because we're sort of working through things iteratively, so it's about half of the participants in the cohort. But this does include the 40 people, I believe, that were enrolled since the beginning of 2023. And so just we can kind of see some big picture things that would help us make decisions about analysis or help us understand the nature of the pandemic, like number of comorbidities. Again, I'm sort of I used to be, before the pandemic, kind of more of a disparities researcher, so I'm always interested in sort of who we're treating, if, you know, age and race ethnicity distribution. I will eventually get back to that work. And then, you know, so looking also at the type of comorbid disease, we know that as the different variants have progressed, they've impacted different individuals, right? And so we'll be able to better kind of track who's being really impacted, which can sort of filter back to care and planning practices. And then incorporating community data. So George mentioned this a little bit, kind of going through and incorporating what was happening in the community. I have much less sophisticated graphs. These are really much more descriptive. But what this is in contrast to George's sort of stress, this is admission. So this is community cases compared to admission rates. So admission is the orange and community is the blue. And then this is to the ICU. And you know, what's interesting for me as somebody that lives in both the clinical and the community world is we had really good community surveillance when communities were doing testing. But as we move to the antigen testing, our community numbers are going to be less and less reliable. So there's a potential opportunity to actually kind of flip that. We've been always thinking about like what's happening in the community so we can predict what's happening in the emergency rooms. But there might come a time, and that might be soon, where we're actually using what we're seeing in the emergency rooms and the ICUs to predict what's happening in the community. And so as antigen tests, as you know, not everyone's reporting their antigen results and things. So again, our ability to sort of understand and link will deteriorate because of the sort of the lack of community testing data, especially in some communities where they've just stopped it and folks are kind of on their own. And our ability to clinically characterize cases with detailed histories and links to sequencing and links to the biologics, I think can really help understand sort of the community. So again, instead of having community surveillance informed clinical care, I think we have the possibility to go the other way around. And so I want to, again, thank everybody. This work takes a village. I have a whole team of analysts that do a lot of this really smart kind of coding and things with me, and then all of my brilliant physician colleagues that are working on the project. So thank you.
So that concludes the presentation part of the portion of the session, and so we have some time for Q&A, and if people have comments also, you can come up to the microphones and ask any questions. And I mean, people have lived the COVID experience also, and so if you have comments or other thoughts about kind of research questions or other things you may want to see that come out of this consortium. Looks like we have one brave soul here.
Yeah, I'll take one for the team and see if I can get a little bit of a conversation going. And I think I may be a little bit agitational intentional just to see if we can get this moving a little bit. I want to ask the panelists about kind of the so what and thinking a few years down the line. A lot of what has come out of this initiative, a lot of what you all have talked about is talking about the realities of policy decisions. Not only the stress on health systems, but the availability of resources, impacts on the community. And we know that all of those decisions were made on the basis of available evidence. And so I think my question is, what is it about this effort that positions us to make better decisions in the future, not just to better understand diseases, but to better respond in real time to make sure we provide more equitable care and we take better care of staff, make sure we have a health system that is sustainable?
That's a great question. George, do you want to take it first?
I'll start. So thank you. It's a very good question. For my niche of this larger project, I'll focus on the staffing piece of your question, which is something that certainly, was something I experienced personally, acutely during it, both in an operational leadership role and a person who was in the ICUs trying to take care of patients during this time period. And the finding that we had here that I tried to highlight, which is that perceived stress, different than quantitative stress, which may or may not be the same, and we plan to study that, but perceived stress persisted for a long period of time after the surge is kind of come and gone. And to me, that suggests, first of all, we need to understand mechanistically what that's measuring. We don't know yet what that is, whether that is true continued disruption of clinical operations or kind of an acute burnout phenomena where the staff is experiencing that even if the actual day-to-day operations have gone back to normal. That's yet to be determined. But I think what it does mean is that as we try to develop better preparedness models that allow for flexibility in staffing and that allow for us to operate within normal efficiency and normal cost, financial constraints, bigger debate, but operating under those normally in a sustainable way, but in a way that allows us to pivot to acutely deal with a surge event, whether that's something as dramatic as COVID or something as routine as a bad influenza month. But we want to be able to design a system that can do that and in a way that takes care of that tail too. And so it's not just let's double up this week, and then we turn back off, and then your staff are kind of exhausted, and you're going back to normal. Is there a way that we can, still accommodate that tail, but again, the realities of it being sustainable, of being, financially viable, and so forth. And so, to me, that was a helpful finding as we think through modifications to our, our staffing models going forward. That's from my niche of this.
If I can maybe address the how do we improve care during a pandemic, specifically the research part. It takes us a long time to change our practice, and even when things are going smoothly, doing the right thing for patients from the time that you finish a study to implementing that into practice takes a huge amount of time. And when you try to do this on the fly during a pandemic, things tend not to go well. And even our group, which had the luxury of strong support from the society and funding, it took us a year to get up and running. And that was with a lot of favorable headwinds. When you contrast this with some of our colleagues in other countries, and specifically, I'd like to highlight the REMAP-CAP group that got funding to set up a study just in case a pandemic might happen. And they were 2.5 or 3 years into a multi-center platform adaptive trial, And then a pandemic happened, and they were able to switch really quickly into testing this. So what I think this shows is that we need to have groups that are actively working. The parent Cobb, who was standing and about to ask the next question, uses the phrase warm base a lot. And you need to have people who are already working together and protocols that are already set up so that we can change care much more rapidly than we did in the past. And I should say that perhaps this is a call for us to get better at changing our practice sooner than the 17 years that it usually takes to bring tidal volumes down to levels that don't injure the lungs or to give antibiotics more quickly.
That's great. Oh, Karen?
I'm loud, but I think we're supposed to use the microphone. And you mentioned policy. I think to sort of both of these points, our research funding sort of structure and environment doesn't support infrastructure. It's all research-based, research question-based, but if we don't know what the question, because we don't know that the pandemic's coming, we don't know what it looks like. I think there has to be at some point a switch in the culture that says we'll invest in coordinated infrastructure to be prepared for research questions. And there are some mechanisms to do that, but they frankly don't always include or incorporate, and this is sort of my equity hat, the communities that are the hardest hit. And so being in Tucson, I'm incredibly grateful to be a part of this network, but we are often left out of these very large networks. We're not a CTSA site, we are a small, but we also take care of incredibly vulnerable communities, like high social deprivation. We're very rural, we have a lot of border, we have a lot of refugee and folks that are coming up from Mexico for care. And so, those communities were really hard hit and we're often left off the table because we have to support our own infrastructure, which means we're saving pennies. And so I think like kind of a fundamental philosophical shift of we need to be including and incorporating the communities that are incredibly hard hit. And we need to be pre-funding some of these things and not just getting incredibly lucky, but having a really good idea, hoping it's coming, and then being able to turn it on.
Thank you.
Yeah. Dr. Cobb?
Perrin Cobb, Los Angeles. I really appreciate the expertise of the group, and I'm so proud of our young investigators, their brilliant presentations and analyses, and yes, Dr. Sevransky, that includes you as well, my friend. So, to pick up on Jonathan's point with sustainability, I couldn't have said it better myself. So it occurs to me that in addition to SARI-PREP, one of the initiatives that Discovery is supporting is a new data science campaign. And I wonder if there's an opportunity under the Discovery, under the SCCM umbrella, for us to discuss for the data science campaign and its charge to determine common data elements for studies like this, whether we could look at sustainability with regard to patient-level data linked to samples, stress surveys, population health, and what a minimal or a core data set would look like that could come from SARI-PREP that could be used as the basis for preparedness common data element data set for the data science campaign.
Does
Yes.
yes, sounds terrific. But I think, John, if you want to talk about the Discovery data science program.
No, I'm not qualified to talk about that. I can barely spell data science, much less talk about it. But what I wanted to mention, and one of the things that data science may allow us to do, is that there's always been a huge tension between having a common limited data set that you can get quickly, that everybody agrees upon the variables, and that a coordinator can correctly identify, and smart researchers who want lots of data on everything. And you end up with a lot of missing data, a lot of data that you're not sure how valuable it is. And so perhaps when we merge electronic medical record data, that much of which is probably true, even though all of it isn't, that we can use data science to both satisfy those who want something really simple so that we can analyze it and get it out to interested clinicians, and those brilliant scientists who are doing exploratory work and want to take a look at some novel things that others may not have looked at. So maybe the data science will allow us to merge both of those difficult to navigate challenges.
Sounds like an opportunity. Thank you. I really enjoyed the session.
Maybe I can just make one more data science comment. I'm not a data scientist, but from a preparedness standpoint, research standpoint, being fast is very helpful in a dynamic scenario. And one of the things you learn as a researcher is that research is often pretty slow. The process is slow, and it's kind of step by step and methodical. And those two things are in conflict when you have an active public health emergency. And so there are more modern data approaches that are emerging for how to combat that. And one of them, which I'll highlight, is changing the role of a central coordinating center from being a data repository where data ends up to being a coordinating center for analysis with distributed data that remains at all the sites where it's individually collected. And so there still has to be the coordination between common data elements and how they're defined and how they're stored, but you remove the process of centralized transport of the data, centralized cleaning, you distribute those efforts, and so that those data live in real time, and then the analysis is coordinated centrally. And that's a much more modern approach that I think is going to play or should play a big role in kind of the new era of preparedness. And so I think that's one data science element of this that I would endorse as a non-data scientist, but someone who would like to benefit from that from a pandemic general preparedness standpoint. Stop there.